Hello everyone. In this session, we will see how to select cases for a case control study. The first step in selecting a case is to define a case or develop a case definition. It's important to understand on how to define a case, which is critical in a case control study. Case definition has two distinct specifications, namely the objective criteria and the eligibility criteria. We all know that disease present with different signs and symptoms, and laboratory test results to diagnose disease are of varying sensitivity and specificity. So the dilemma is what combination of signs and symptoms and laboratory test results can be chosen to define a case. We have to define a case in such a way that it has high diagnostic certainty so that we reach a definitive diagnosis. If we define a case with high diagnostic certainty, then we can minimize false positives. We always recommend to use standardized definitions as prescribed by WHO or CDC, but in Indian context, we can use definitions recommended by Integrated Disease Surveillance Program, especially for infectious diseases. Eligibility criteria. These are the set of restrictions we place in order to select individuals for the study. The restrictions should reflect such that cases are potentially at risk for exposure. Example, in order to establish a relationship between recent OCP use and myocardial infarction, we might exclude women who are sterilized or women who are post-menopausal because they are not at risk for exposure. Also, cases should have reasonable possibility of having had their disease induced by the exposure. Example, in order to determine a relationship between OCP and thromboembolism, we might exclude postpartum and post-operative cases because postpartum and post-operation are risk factors to develop thromboembolism. Selection of cases. We have to select cases such that they are representative of all the cases of interest in the source population. We can do this only by doing a population-based survey, either by a community survey or by screening all the individuals in the populations. But that is a very ideal conditions. And it cannot be met with in real life conditions. We generally recruit cases from hospitals. When we recruit cases from hospitals, then it will be restricted to a subset in terms of severity of disease or in a defined geographic location or in a defined time period. Here, we are implicitly sampling from a subset of total population of cases. It can be either hospital-based or population-based. In hospital-based, the advantages are it is very easy and inexpensive. Disadvantages, as I described earlier, that it represents only severe cases. It might not be representative of all the cases in the community, but however, instead of recruiting from one cases, if we recruit cases from multiple hospitals, this can be taken care of. Also, in population-based, it is better for selecting a representative group of cases, but disadvantages, it will be time-consuming and expensive. Population-based selection of cases can come from registries or from disease surveillance data or from a cross-sectional community survey. The next dilemma is to select prevalent cases or incident cases. Incident means newly diagnosed cases. Prevalent cases means they are the old surviving patients. Incident cases will be more optimal for a case control study, but we have to wait for cases to occur in order to recruit them as cases, and that can be time consuming. But problem with prevalent cases is prevalent cases do not include patients with a short course of disease. That is, patients who have died will not be included in a disease. So the risk factor under study may be associated with survival rather than the development of disease. Remember, in selecting cases, case definition is very crucial and the selected cases should be representative of all the cases of interest from the source population. Thank you.